Good morning, everyone. I thank Dr. Shona Nag and Dr. Sudeep Gupta for the kind invitation and the entire team of Year in Review. The abstracts that I have to present here have been presented in the SABCS conference in December, and the first one is the MAMO 50 trial, which is a surveillance randomized controlled trial for patients aged 50 years or above, and it is a non-inferiority trial comparing annual versus less frequent mammography for patients who have been treated with early breast cancer. The current guidelines in the US and Europe recommend annual surveillance mammograms for an unspecified period after treatment for early breast cancer. The guidelines in UK recommend annual surveillance for 5 years and then revert back to 3 yearly screening. Annual mammograms are significant cost burden to the healthcare system there and also cause anxiety to the patients. Therefore, it was a call commissioned by the UK NIHR to find further evidence to determine optimum frequency and duration of mammographic surveillance. So this trial was designed, it was a multicentric phase 3 study where women above 50 years of age who were previously treated curative intent for invasive or non-invasive breast cancer and after 3 years of post-curative surgery were inducted into the trial. There was the annual surveillance arm and a less frequent arm where women with wide local excision were called for 2 yearly follow-up, while those with mastectomy were called for 3 yearly follow-up. The primary outcome was breast cancer specific survival and cost effectiveness, secondary outcomes of recurrence-free interval and overall survival. A quality of life sub-study was also done. And the results, 5,235 women were randomized between April 2014 and 2018. In the recruitment, majority of the women were above 60 years of age, and 80% of women had undergone wide local excision, and 87% had a diagnosis of invasive carcinoma. The tumor characteristics, majority of tumors were less than 2 centimeters, grade 2 and less differentiation. They were node negative and ER/PR positive, HER2 negative type of tumors. The median follow-up was 5.7 years and total of 8.7 years post-curative surgery. 7% of women died and 7% developed breast cancer recurrence. The primary outcome was the primary analysis was carried out on the intention to treat basis, and the sensitivity analysis was done for the per protocol population. So the 5-year breast cancer survival was 98.1% in the annual follow-up as compared to 98.3% in the less frequent follow-up arm. This was the breast cancer specific survival. The recurrence-free survival was 94.1% and 94.5% in both the arms, and there was no significant difference. The overall survival was 94.7 and 94.5% in the annual and less frequent follow-up arm. Compliance to the allocated schedule was good in the annual and as well as the less frequent, although it was slightly lesser in the less frequent follow-up arm. Conclusion was unchanged after sensitivity analysis of the per protocol population, and there were few missed mammograms in the annual follow-up as compared to the less frequent follow-up. The quality of life remained similar over time in both the arms. The author concludes that MAMO 50 demonstrates that patients above 50 years of age or older and 3 years after diagnosis or complete treatment of the disease require less follow-up, and less follow-up is non-inferior to annual mammograms. 24% of women having persistent, moderate to high levels of distress suggests that need is there for ongoing survivorship support. There is a need to have a mechanism for easy access back into the system for symptom management. This can be clinical practice changing guideline for women above 50 years of age. As part of the discussion, majority of patients in this study were above 60 years of age, and the median age for invasive breast cancer in those countries where this study was conducted is above 50 years of age. The tumor size was small, it was node negative and ER/PR positive, HER2 node negative population, which is a low risk population, and they had majoritarily undergone wide local excision. A subset analysis may be done for the HER2 node negative population. The cost effectiveness data was not presented, but the less frequent subgroup of 2 yearly mammogram would have halved the cost of this at the same effect. Among the 7% of the women who died, majority died because of non-cancer or other cancers. Therefore, consideration for geriatric oncology support for breast cancer patients can be considered. Less frequent mammogram group of patients are less likely to comply to schedules in a controlled setting, although, and the frequency of missed mammograms, although, is low. But still, this highlights the role of greater patient engagement for implementation of less frequent mammogram protocols in actual practice. The distress levels that were significant throughout the follow-up and similar in both arms can be post-treatment, or they can be because of the postmenopausal effects, other than owing to directly due to mammograms. The study was conducted after a national rollout of screening program using digital mammography, which has a better sensitivity for early detection. Majority of patients in our country and in low middle income countries may have present with locally advanced ages, younger ages, and follow-up compliance is poor. Therefore, results of Mammo 50 may not be applicable to such populations. This was not presented in the study. This is just if we look at the cost effectiveness of this intervention, then it would be reducing the costs but not having an impact on the effect. Therefore, it would lie on the cost difference line and not in any of the quadrants. The take-home message from our side is this results on survival after less frequent follow-up will be practice-changing for low-risk population. The strategy may be cost-effective for the same population without being generalizable. There's a role of enhanced patient engagement for improving compliance to follow-up in less frequent mammograms. And the study also elucidates requirement of survivorship care for such patients with easy access to menopausal and geriatric health support. The second abstract is a meta-analysis, overview of axillary treatment. Yes. So this meta-analysis was also presented in the SABS BCS conference, and they have taken studies. Okay. I'll just maybe verbally, they don't have the slides, I'm sorry about that, I did share it. So the meta-analysis is done from studies starting from the pre-sentinel lymph node biopsy era in the 1950s and then up to 2010, after the sentinel lymph node biopsy became the standard of care. And they have okay. So they were looking for the endpoints, and the event rates have been compared between the more treatment to axilla and the less treatment to axilla arms in various studies. So before the sentinel lymph node biopsy era, there was either axillary dissection, extensive surgery compared with radiation, or less extensive surgery compared with radiation. And in the post-sentinel lymph node biopsy era, they've compared sampling to no sampling, or dissection to no dissection after sentinel lymph nodes. And the results that they have is that there is no, the less treatment is the more treatment prevents axillary recurrences, but it does not have an impact on overall survival or mortality. And they've also, there's significant lymphedema after any kind of axillary dissection. More dissection, of course, we all know it is. So overview of axillary management in early breast cancer. This was conducted by the Early Breast Cancer Trialist Collaborative Group, UK. Post-treatment lymphedema after surgery is significant. Trials are on less axillary treatment in the form of no axillary treatment or only radiation, comparing extensive axillary dissection or dissection with RT were conducted between 1950 to 2000, and then sentinel lymph node became standard of care, demonstrating its role in predicting prognosis and guiding extent of surgery. These trials also compared less versus more treatment to axilla in the form of SLNB and AD versus SLNB alone. The aim of this meta-analysis was to find endpoints of loco-regional recurrence, distant recurrence, and breast cancer mortality from different treatments to the axilla in early breast cancer, comparing less versus more treatment. The effect of...
Can you come towards the end where you have already explained all that? So please come.
So the results are that trials which had more versus less axillary surgery, the risk of loco-regional recurrence was low in more axillary surgery. There's no evidence of an effect on breast cancer mortality, although. And in the sentinel lymph node trials, increased lymphedema, the significant morbidity in more axillary surgery or dissection arm. In the trials comparing axillary dissection with radiation, the risk of loco-regional recurrence is reduced. There is no evidence, although, on the effect of mortality. And the sentinel lymph node trials increase, again, surgical intervention increased lymphedema from surgery. So the author concluded that axillary recurrences are halved from more versus less axillary surgery. Axillary recurrences are uncommon with no observed effect on mortality, and more surgery increases edema. Therefore, axillary RT reduces edema risk compared with surgery, but there's too little data on long-term regional recurrence. Discussion from my side is that we can have randomized trials proving this, maybe without sentinel lymph node in one of the arms. Node positivity predicts distant recurrence, but it does not have an impact on survival. And more axillary dissection does not impact overall recurrence rate, but reduces the axillary recurrence at the cost of lymphedema. Thank you.